he is a radiologist, finishing up his tail end of his residency, and he's going to talk to us, kind of give us a general radiology introduction, and then focus in more on the chest X-ray. So thank you, Dr. Beck, for being here. I'll let you talk more about yourself if you want.
Okay, so I got two PowerPoints here. The first one is just introduction to radiology. I'm not sure exactly what you guys have had. I've been told that you've kind of seen some things here and there, but even when I was going through medical school, we hardly had anything to do with radiology. I only saw enough of it during my master's to even be interested in it. So I'm just going to briefly talk about different stuff that you might see in radiology. And then after that, we're going to go to the chest module. That's what you guys are working on right now. So hopefully it'll just be a brief overview. I've heard that you guys went over a lot of this stuff already, like the disease pathology. So this is really just going to be a correlation with what you would see on an X-ray, rather than actually talking about what the disease is itself, or things like that. So these are the objectives. You guys can just read over yourself. So what is radiology? It's the practice or science of utilizing imaging to contribute to the care of a patient. Generally, you know, radiology now is ordered all the time, but initially it's really was supposed to be treated as a consult for the doctors when they needed help on what was going on. Now it's a vital tool to help to distinguish different pathologies. It's also used for treatment as well. So we don't just use it for obtaining images and interpreting of it. It's also used for like I said, procedures and treatment. Certain procedures are possible because of radiology, and that really gets into interventional radiology. If you guys don't know what that is, basically, interventional radiology is basically the least invasive method of treating certain diseases. It's basically just using guide wires and catheters going through access such as the femoral artery. Also, we use it for biopsies, and generally it's under ultrasound or CT. Aspiration, basically just pulling fluid out of the lungs, the abdomen, putting in chest tubes, drainage catheters for abscess, and then getting into the spinal canal, called lumbar puncture. Also, again, we use radiation to monitor and treat neoplasm or disease. That's the nuclear medicine aspect of radiology. And there's a thing called fluoroscopy, which, if you don't know what that is, I'll go over it here in a second. It basically gives us indirect visualization of balloons or cavities inside of us. So really the bowel, the uterus, urinary system, things like that. And then lastly, joint injections, so arthrogram or drug delivery such as steroids or lidocaine to help treat their joint pain symptoms. So when we think of what is radiology, I get asked a lot, what I do, and I'm a radiologist, and a lot of what I get is like, a lot of people don't understand that when you order the study, they think it's the referring doctor, or the doctor that orders the study that actually reads everything. And yeah, they should look at everything too, along with when you guys order stuff, you should look at as much as you can. But as a radiologist, we're the actual physicians who interprets or reads the studies attained by the technologists. So here, this is just to show you that the training that we go through, it's not to like toot your own horn or anything like that, but when I talk about radiology here, and then my colleagues as well, when they come give you guys lectures, it's very, 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 very compressed. I mean, we go through 4 years of just residency alone, and there's also 1 to 2 years of fellowship. So we're trying to compress everything we can in one hour, 1 to 2 hours, just to kind of give you guys a good foundation to build off of, especially when you do the rotations. These are the different fellowships that radiologists can get into or subspecialize in. A lot of different fields out there. There's body. MSK is musculoskeletal, so that's basically just muscles and joints. Neuro, mammo, IR, which is, again, the interventional aspect of it. Chest, Peds, and MRI. MRI is a relatively new fellowship. So then we also have the technologists. They're the ones who actually work with the patients directly and obtain the images. They also subspecialize as well. There's usually a sonographer, ultrasound. There's different types of sonographers out there, whether they do mammo or breast sonography or OB sonography. Then there's radiographers themselves. They have X-rays. They also have fluoroscopy. Then there's also different types for the CT and MRI, nuclear medicine, and then IR. And then there's the physician assistants. I was actually unaware until I actually got into my residency that there was physician assistants for radiologists. But from what I've seen with my experience, really they mainly work with IR, and that's for different procedures to help assist with radiologists. They do their own procedures as well, but they also help assist with radiology procedures. Again, directly working with IR radiologists. So these are the different modalities. When we think of radiology, there's the radiographs, also known as plain films. For the layman out there, it's X-rays. There's also fluoroscopy, ultrasound, CT, MRI, nuclear medicine, IR. And then with each of these, we can give contrast or we don't have to. Generally, when we give contrast, there's different types out there that I believe in another lecture we'll go over. We generally give contrast for specific reasons. We look for blood, infection, cancer, tumors, things like that. And when I go over some cases, especially when I come back for GI and peds, you guys will know exactly when you should give contrast or order it, with contrast or without. And there's also intraluminal contrast. This is stuff that we either ingest orally or we use a rectal catheter called enema, and then we can, look at the bowel lumen and things like that. So when we think of radiograph or plain film, again, X-rays, they're interpreted in regards to the relative density. So we use the term radiopaque or radiolucent. Generally, the more dense an object, the more white it's going to look on an X-ray. The less dense, the less white, or the more black it's going to be. So like bones are going to look really white, while air is going to be just black. So that's because the denser objects will attenuate the X-ray beams that are created and appear whiter on the film. So with X-rays, you're kind of limited to 5 different densities that we can distinguish. Going from least to most dense, the most black is going to be air. The most white is actually going to be metallic artifacts, foreign bodies, pacemakers, things like that. So you can see here air, fat, soft tissue, calcium, and metal. So if you keep these in mind, it'll help you a lot on determining exactly what you're looking at. So these are the 5 different densities out there. So here we've got I'm just skipping ahead for okay. So we have 5 different densities here. So here we have metal, and then another one's going to be bone that we talked about. I'm kind of from most dense to least dense. Soft tissue, when we think of soft tissue, it's basically water density. So like kidneys, for example, this is the kidney outline right here. Anything that's soft tissue that has water, that's going to be its own density. And then the next thing is going to be fat. So this, like right here, the fat surrounding the kidneys, right over here, that's going to be less dense than the soft tissues and kidneys as well. And then after that, we get into air. And you can see this is just a gastric bubble for air in the stomach there. So again, keeping these things in mind, that's basically all you need to know as far as how to distinguish different things. Next is fluoroscopy. So this actually utilizes X-rays as well to evaluate and we use X-rays to evaluate and to perform different procedures. Often we use it with GI tract. This allows us to view what we're looking at in real time. Usually it's with the use of intraluminal contrast. So again, we can either have the patient drink it, it can be oral contrast, or we can give it rectally as an enema. And we also use contrast to look at the uterus and cervix. This is called a histosalpingogram. Cystogram is just used to evaluate the bladder. VCUG is another way to look at the bladder and the ureters. As we fill them up, they void, and then we can look at the urethra as well. Then also we inject contrast under fluoro for arthrograms. So we inject contrast under fluoro to make sure that we actually get the contrast in the joint. Then after that, we send them over to CT or MRI so they get further evaluated. So these are the different fluoro exams here. So esophagram is going to be one of them. The contrast can either show up black or white. It just depends on how we set the image parameters. But just know here that again you get a nice look at the esophagus, and you can look for different hernias, hiatal hernias, things like that, stricture of the esophagus. These are just examples. I know peds is going to be kind of chest is going to be the module for today, but this just gives you an idea of what a fluoroscopy is. And again, we're looking at hernias with an esophagus, things like that, in the stomach. If we move forward, we also have upper GI small bowel fall through. This is another fluoroscopic exam that looks at the stomach, the pylorus, and the proximal duodenum there. Further along, this is just another upper GI examination. Small bowel follow-through is where we have them drink the contrast, and all we're doing is just following the small bowel. We're not actually following each individual loop, but it tells us that if there's any obstruction, dilation of the small bowel, things like that, that needs to be handled surgically. And this is just another look at the terminal ileum, which is, looking at strictures of the terminal ileum, which you often see in Crohn's disease. Then colon divided up here. Air contrast bearing enema, so this is where we've inserted a rectal catheter, and we basically have just dumped contrast into the colon. We drain them out, and then we pump air, and that gives us a nice picture here to show us the entire colon all the way up to the terminal ileum there. And then again, we're looking for polyp strictures, which would indicate any kind of cancer, things of that nature. We also have ultrasounds is the next modality. So the pros of an ultrasound is that there's no radiation. It's very, very inexpensive compared to CT, MR, and ERCP. This also allows us to look at blood flow in real time. This is really important when we're trying to do certain biopsies. We know that we can avoid vessels as we're sticking the needle in, and we can view the blood vessels in real time and avoid those. The cons of this, though, is very, very, very tech dependent. So it depends on the competency and reproducibility by the tech. Again, just some institutes have different protocols for what the tech does, and so it's a little bit hard to get the same reproducibility when you're trying to compare ultrasound to ultrasound. And also we have limited window of visibility at times because things like body habitus, if the patient's very large or obese, or if they have a lot of bowel gas because they just ate a meal, that can also limit our window to viewing the abdomen and things of that nature as well. So when we talk about ultrasound, there's difference. We talk about in terms of echogenicity. So again, X-rays was density. Now this is echogenicity. Echogenicity is evaluated in regards to its surrounding tissue or environment. And what it is it's the ability of an object to reflect the sound wave echoes that are going towards the patient and bounce back to the transmitter probe. So, really, it's kind of the same concept. We've got, very black anechoic to white, which is highly reflective. That kind of holds true when you're looking at what is dense would be reflective on an ultrasound, but there are certain things that aren't going to hold true when moving from X-ray to ultrasound. For one of them, it's going to be air and fat. So air and fat are actually going to give you echogenicity. It's going to look white on the ultrasound, where on the X-rays it looks black. That's just the simple physics of it is that it's just really reflective. That's all. I would just keep that in mind. So this might be a good way to be tricked if you guys are looking at ultrasounds yourselves and you're seeing a very, very dense object. Just know that air and fat can be the differential for that as well. So CT uses X-rays. So just like a X-ray is for plain film or radiography, we actually use X-rays to obtain a CT image. So the way it works though is that we throw X-rays on someone as they go through the scanner, and so it just does 360 spin and throws X-rays at them. Basically, the scanner gets the information back, and it uses a computer to process the image and creates a nice 3D picture. It does give us better tissue contrast when we compare it to ultrasound. It does have high spatial resolution, which is going to be very important when we compare it to MRI. It does have great reproducibility. Basically, all the tech needs to do is enter the parameters, and then they just send the patient into the scanner, and then the scanner does everything it needs to. And then we can also reformat things in different planes. The cons for this, though, is that it is radiation. So X-ray, the plain film, those are radiation because we use X-rays. Ultrasound, again, no radiation because it's just sound waves. But this one does use radiation. And again, X-rays are used for these images based on density, just like we talked about with the plain film. And iodinated contrast is often needed to detect or further evaluate certain lesions. But the reason why I put this as a con, because people with renal failure, for example, or certain allergies may not be able to receive the contrast. So that can limit you as well. So when we talk about CT, again, we talk about in terms of relative density of objects. We measure in Hounsfield units with relative values measured against water. All you need to know is just really what I've quoted here, is that when we talk about CT, we talk about its density. So again, X-rays, plain film, and CT, its density. And then when we talk about ultrasound, it's reflectivity, and we refer to that as echogenicity. So when we talk about planes of a CT, we always acquire in the axial plane. So the patient lays down, and then they go through the scanner. It's always acquired in this axial plane here. Basically, it's just like slicing them just like this right here, the transverse plane. If we want to get a better look at certain disease pathology from the side or from the front, this is sagittal, this is coronal, the computer can actually take the image and reformat it into these images right here to give us a nice different look. And we can reformat it to whatever plane we want the computer to. But again, this is allows for different look at the pathology for better spatial understanding. So you know, if you have a hard time wrapping your head around if something is anterior, superior, or whatever it may be, having these different looks can really just be beneficial for you. And then I put this in there so you guys can just see the correlation between ultrasound and CT. But as far as anatomy is concerned, I wouldn't hit home too much with this unless it was part of your test. And then the other thing that we want to talk about is MRI. So MRI is magnetic resonance imaging. The pros to this is that it has better contrast resolution. So I said CT has better spatial resolution. What I mean by that is like, you can get the smallest pixels possible with the CT better than we can with MRI. But when I talk about contrast resolution though, MRI can distinguish different tissues that appear very, very similar a lot better. It can differentiate those tissues a lot better than CT can. And that's really good for stuff like the brain, where there's white and gray matter that has very, very similar densities, but the MRI can distinguish those different densities very, very, a lot better than the CT can. Another pro is that there's no radiation. The reason why is because it uses radio frequency pulses and gradients to obtain images based on their interaction with the proton. So in short, we basically use RF pulses or waves that the MRI produces. It gets shot over to the patient, it interacts with the protons. When I'm talking about protons, we're talking about basically hydrogen, and hydrogen is the most abundant source in the body because hydrogen basically is water. So we're just evaluating more or less how much hydrogen or water each tissue contains that we're trying to evaluate specifically. The good thing about MRI also is that imaging can be obtained in any single plane. So here with CT, it has to be axial, then you have to tell the computer to reformat it. Well, with MRI, we don't have to waste our time doing that. We can acquire in any different dimension or plane that we would like. And also, we can set different parameters to obtain different MRI sequences based on what we want to concentrate on. So we can actually tell the computer, the MRI here, that we want to evaluate specifically fluid only, or blood only, or fat only, and it gives us different types of pictures and helps us to ignore everything else if we're only concentrating on blood or fat or things like that. I'm not sure how much you guys are actually going to be looking at MRI, but again, this just kind of gives you a nice broad overview. I believe myself and some of my colleagues will review some of the MRI pathology with you that you might encounter. So some of the cons with it, it's got poor spatial resolution. So again, contrast, it can really distinguish very, very small pixel size. MRI does not do that as well. So as we zoom in or we try to observe very small pathology or lesions, MRI cannot do that very, very well at all. It's also susceptible to abundance of artifacts such as hardware, motion, imaging parameters, the patient's body habits. It's very expensive, and at times, this is probably not going to be as much of an issue with, as we get more terminal radiologists, but a lot of the radiologists, that they didn't go through their training with MRI, and that wasn't really even available until, I guess, mainstream about the 90s or so. So again, sometimes you'll get a radiologist who not feel comfortable with that. So that's why I just talked about that there's MRI fellowship that is offered now to get subspecialized in. And so with that also, there's also safety issues. You guys probably heard a lot of stories about MRIs being strong magnets. Things get thrown across the room. That is true. People have died from that in the past. You can find articles on that easily about oxygen tanks. where a nurse or something will wheel it into the room and it goes flying across. I mean, it's killed people before, so it's, you know, this is something, again, the tech should be very, very aware of. But just, if you guys are hanging around with a patient, you walk into the MRI room, just be sure, you know, to keep that in mind about any magnetic objects with you or on you or around you at the time. So when we talk about MRI, we use the terminology intensity. It refers to how hypo or hyper intense signals are in terms of shades of gray of the tissue or fluid relative to its surroundings. So basically, just like ultrasound, where we're looking at echogenicity or reflectivity, we're actually comparing it to its surrounding tissue. Same thing with MRI, we're comparing it to surrounding tissue. Just to recap though, X-rays, you know, for plain film and CT, those are not going to give you absolute density. There's no relativity involved. So here we're going to talk about hyperintense, which is white, hypointense is black. I just throw this little box up here. Just be familiar with these terms here, because when you hear other people talking about it, you know, this will help you give you a nice framework of what they're talking about exactly. When we talk about intensity, we must reference it to the sequence we obtained. So there's T1 and T2 weighting. Again, this is just something that you can easily look up to get a better understanding on, like Wikipedia, or not Wikipedia, Wiki Radiography, radiopedia.org, or there's also books out there. But again, this is just going to give you a nice foundation there. So some common examples of MRI sequences that we do obtain. Here's the whole list of them right here. So when I talk about we get an MRI, we can target certain tissues. Again, fat, blood, soft tissues, fluid, whatever we want. And these are the different ways we can do that through these different sequences right here. And I'm not going to go into detail exactly what each of these are. And then learning these sequences are beyond the scope of what you need to know. Just know that there are many sequences out there to target certain things. Again, this is the sequences we obtain. Specifically, when we look at certain things, these are the ones that we get here. So if some of you guys are going to be in like neuro, for example, this will be really good to understand that when you're looking for blood after you scan a patient, and you'll probably learn this too as you go through your rotations as well, but you know, grab the GRD sequence, look at that, look for any blood on there. If you want to look for any infarction where someone's infarcted their brain, you're going to go to the DWI sequence, you know, so on and so forth. Nuclear medicine, we use radioactive agents or substances called radiotracers, which are usually injected into the bloodstream, or it's orally ingested, or it's inhaled. These radiopharmaceuticals are designed to tag specific tissues, bones, organs, and then after enough time has passed for the agent to localize to the specific tissue or organ that we're targeting, we image the patient. The camera then grabs the radioactivity that's emitted by the tracer there, and it helps determine the activity level and the distribution of the targets to diagnose pathology. So basically, if we want to look at splenic tissue, there's a certain radiotracer out there that we can give the patient that will localize specifically to splenic tissue. But then if you are wondering if they have splenic tissue elsewhere, which can happen, this will tell you exactly where it's emitting from. Because, for example, normally you would want to see it where the spleen is, but if you see anywhere else, then you know that there's also splenic tissue there as well. But commonly we use these studies to look for any GI bleeding, gastric emptying studies. So this is for the gastroparesis patients, your diabetics. We do VQ scans, which you'll get a lot. These are lung ventilation and perfusion scans. These are for people who cannot get a CT-PD protocol. So if you're worried about like pulmonary embolism, you can get a VQ scan to evaluate for embolism if the patient cannot get contrast, which you'll encounter time to time as well. We also use it to look for cancer and tumors to diagnose for surveillance and for treatment response. There's bone scans that you can get if you're worried about metastasis to the bone, osteomyelitis, things like that. And then we also use it to evaluate renal function as well. This is just an example. It's called a HIDA scan. Basically, this just gives us a nice look at the gallbladder. And you can read all of this, but again, this is all going to be summed up in the GI section as well. This is just an example of the GI bleeding scan. Again, you can read this if you want, but this just shows you what a GI bleeding scan would look like. You know, sometimes it can be very, very subtle though. Like normally, this is what you should only see if you see activity, for example, like right there, that little guy, then that's a bleed. And because because it's radioactive, because the cameras are very, very sensitive, this can pick up very, very whole, or very, again, small, minute pathology that you would never see with a CT scan or MRI or anything like that. So nuclear medicine has its place as well. So that was a dry topic. I always felt like introduction to radiology is like something that, you know, it's kind of boring. And I'll be honest, like it was something that, you know, as a med student, I didn't really care for too much. But then when we get into chest pathology, I think this is going to be more of a hit home with you guys that you're going to see. No matter what field you go into, everyone gets a chest X-ray. So I'm not, again, when we go over this, I'm not going to go over specific pathology itself. I'm not going to teach you what pneumonia is or anything like that. Hopefully you guys should have a pretty good grasp on that. But this is going to be correlation with what you would see if someone had pneumonia and things like that. I'm going to go through search patterns with you guys and things like that. To be honest, this is probably a good break point because there's not going to be a really good one here. So if you guys want, just go stretch for like 10 minutes, come back, and after that, we're going to try to run through this, and there's 52 slides, so, you know, I'll go ahead and take a break.
I mean, it could be because I don't know. What? Oh, it's not at all, but so maybe
That's how I feel.
It's so
No matter what I do, I fast forward and I'm like, that's not enough time to study. Like it's never there. Even when I tell myself during the day, I'm gonna at least do. I told her when at least
trying to talk to her. It is new weekends, which I understand.
Okay, I'm gonna actually do it here.
Yeah, I didn't bring my. I know they have this. What's that mean?
That's also a lot that we've seen, but I think it feels just all it doesn't like just not that. Like looking at it, you go every weekend, that goes every Monday.
Yeah.
You know, like a little grandma. I feel like I could try it.
I can ask Monica to put
I mean, Saturday to help, but I don't have any on the setting. Besides that, I don't know. I lied. What am I doing?
You're about to be told what you asked for.
Oh yeah, no, I definitely need my watch. Let's text her and be like, can you put my hair up?
Yeah.
You got the last one of the day. Okay. So tell her to like walk my nursing process.
We'll bring a bottle of wine.
Yes, please. Oh my God.
Oh yeah, she'd be down for that.
Yeah. What are you doing, Sarah? I'm going back to what it was before I graduated. Was it blondie? No. It's like, you're gonna drop them. No. They are. They're like out there.
Yeah, I know.
Yeah, they are.
I have more partners on, so I'm going to screw my partner over.
I went dark for like the beginning of fall. And like, that's fine. My nephew is it's like really ashy. I've never done it, so I always put highlights in it. I'm trying to get back into that.
All of us.
I think Numa has air. The one air one. Because Numa, yeah, Numa.
which one sounds better?
Yeah, that's what we were doing last night. We were like, we have no idea what seal. There's no hard fast seal. We just had to say all the options of which one sounded better.
So we were like, oh,
Yeah, it's fine. Diaphragm.
what's the one that it's diaphragmatic. There's one that's yeah,
Seal.
yeah.
That's the hernia. We're saying first.
I might Charlie.
There's another.
Yeah, that's what I Polly, some
I kind of feel like I'm that's in the this is like lack of blood. They're both tissue, but this one's
well, there's anoxia. It's the second okay, deprivation.
Yeah. I have it. Separate.
less than adequate. Less than adequate. Like,
That means the same thing.
To supply.
it is. Yeah. They're both tissue. Already Google it.
Hello. Online portal.
When you're trying, you're just trying. I mean, I gotta go with back up. Is it when you see it? But they're both
Nothing found.
That's my
Here's some wrong. Yeah, no, but yeah, they found acyclic trauma, squamous cells, and undetermined signature.
That's when you're like,
I don't know.
in the blood.
There's a two, I don't like the two-step discrepancy between the phase. So this, my half of the the whole row came back and no, that's what I got. That protein will come back and pass. And then she sent all this stuff.
I literally take my hair.
So, I wonder if I'm message just the nurse though. Like, I don't want to message doctor, driver. I remember. Urogynecology. Actually, no. That's weird. I was gonna say, I know a nurse practitioner that does urogynecology, and my last name's Ritchie. She said we Ritchie. That's funny.
You consider radiology?
Oh, those are all the providers. I just kind of
I don't know how you go about it.
bet it goes to the I put on her last one because you don't know what is one type. What price is it? I was like, this list is getting too long. And I literally just put on
Yeah, I really don't know radiology.
I thought that was so quick. It might be it may be Thank you. God, Wow, I'm an idiot. $100 off. Did I screw this off? I know, right? This is how I go the Yeah, culture and chest
Yes.
like
Yeah, I have no idea.
the whole thing. It does. Oh yeah.
I need a Sarah's still looking for the one thing. I know. Yeah. No
Alright, so hopefully this is a more interesting lecture for you guys. Again, the other one's a little dry, but this should be more